You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have Dr. Paul Anderson, CEO of the Anderson Medical Group, and we're going to be talking about outside of the box cancer therapies. Super important. So, Paul, thanks for coming. How are you doing today?
Doing very well. Thanks for having me.
Yeah, tell me, what got you into even looking at alternative cancer therapy treatments?
Well, I've been involved in the world of integrative medicine for about 25 years or so at this point. And early on, I had more of a general type practice, at least the first couple of years. And what happened was back in those days, it was pretty unusual to find practitioners who would even, be interested in integrative or naturopathic or alternative cancer therapies, because it was fairly hostile towards that back then. And once people found out you did it for other things, they started to come with, cancer and other types of chronic illness. So it really triggered. Well, I mean, there's two ways to deal with that. One is tell them no, or the other is, you have a steep learning curve. So of the modern probably era, I was one of the people, who got into this at a time when some of the information was really starting to come out about potential benefits for integrative therapies. So that's what started it, but it was really driven by the fact that the patients needed it, and there wasn't a lot known at that time. So that's kind of the beginning, anyway.
What are some of the the out of the box therapies? Everyone seems to know about chemo, radiation, resection by surgery.
Yes, certainly. Those are the chemo, radiation, surgery, or the big three, as they call them. I think that one way to look at it, which is the way we usually speak with patients about it, is those things might be totally appropriate. Sometimes they work quite well. Sometimes they don't work very well at all. And as I say, sometimes they're totally appropriate, but they only address a small part of the problem. Now, if you have a really aggressive active cancer, that small part can be very important. So I'm not minimizing that. But what I usually tell them is that, none of those therapies deal with the entire rest of the person that has normal cells, non-cancerous cells that we need to keep working. Otherwise, they won't live, through therapy, et cetera. So when you think of it that way, then it's less of a say either or an us versus them. It's really those therapies target the cancer itself for the most part. And what we try to do is work with the rest of the person to keep their immune system working, which helps you resist cancer, growing or coming back. And there's a lot of ways to work with the immune system and the normal cells to keep them also on track. So there are a lot of, depending on what the target is, there are a number of things in diet and nutrition that are beyond the big three: cancer, chemo, and surgery and radiation. But also on top of diet and nutrition, now we know a lot more about things from the plant world, herbal type extracts, mushroom extracts, and things that actually have pretty good hardcore research behind them. It's just that they're kind of slow to get into the system. So we use a lot of those type of things as the base, and then there are more, I guess, invasive or advanced type natural therapies that I've done a lot of work with and done research with. that would be like injection and intravenous type therapies using natural substances. So one most people have heard of is, say, high dose vitamin C or low dose vitamin C by an IV. There's a lot of other things that that go that way as well. And then there's a lot of things that even 10 years ago wouldn't have been on the radar of much of anybody, but are really coming much more on the radar, even in standard oncology. These are what I like to call some of the lifestyle and hygienic type things. So, for example, the if you get somebody who has cancer to start to move and do just the smallest bit of exercise, and it's to their tolerance, of course, they actually have longer life associated with better muscle activity. So, meaning keeping your body moving. Things such as intermittent fasting, which is something the patient can control, which is a time during every 24-hour period where you're not eating, drinking water, but you're not eating. That's been associated with some studies and extension of life. Um, and then a lot of mental emotional things. So it really covers a pretty wide gamut of areas inside the person and the patient who has cancer that don't have anything directly to do with the other therapies that they're doing, but they're very supportive.
And the alternative therapies, I've heard diet interventions spoken about a lot, but I've also heard, unfortunately, many doctors and scientists saying, "Oh, there's no peer-reviewed evidence that diet affects cancer at all," which sounds pretty ridiculous to me. The cells of your body over your life. What's the energy balance? What are they taking in? Air, food, water, but yet that has no effect. I mean, it sounds ridiculous to me. But what's your
Yeah,
thoughts there?
yeah, it is pretty. It's I mean, it is ridiculous. Yeah, it's and it literally, I remember, say, 20, 25 years ago, working with other doctors more in the the standard world of medicine, and hearing them very authoritatively tell patients, well, your digestive tract complaints, whatever they are, have nothing to do with what you eat, which just sounds like the most insane thing in the world to say. But that was the prevailing thought. And diet, if you brought it up around cancer, it was like, no, they need to eat anything they want, and a lot of like ice cream and all this stuff to keep their weight on. And if you look at any of the research now, and one of the things about the book Outside the Box that Mark Stengler and I did, that Dr. Stengler and I co-wrote it, was we referenced everything that we talk about, and we have over 1,000 peer-reviewed references. So when you get to diet or intermittent fasting or these other dietary related things, there's a lot of references. So a doctor who says there's no research is just they're either uninformed or they're lying. um, it has a huge effect, obviously. Now, what they sometimes will talk about is, once the person's cancer is very active, a change in their diet may, on one hand, be very necessary. On the other hand, they may not notice a big change in a super active cancer. That doesn't mean it's unimportant. It's very important to change, how and what you eat. The problem in North America that I found is, and I say North America because the idea of integrating diet is much more accepted in other parts of the world. Um, the problem in North America is they still look at like BMI and say, well, you're losing weight, so you need to gain weight. And they essentially, it's any kind of weight is okay. So they have people eat, ice cream and donuts and crap, which just puts the body into a chemistry state that fuels cancer. What the research shows is BMI is a worthless measurement. What you really need to look at is how much muscle mass are they gaining. If you just gain fat mass, you die faster. So you can be heavier but dead quicker. So what we really work on with people is as clean a diet as possible, and then as high impact. So whatever you put in your mouth to eat has very dense nutrient sources, has really good nutrient sources, doesn't have a lot of sugar, doesn't have a lot of insulin triggering things. And those diets actually are associated with not only building muscle mass but longer life. So yeah, but in America, especially in places where there isn't a lot going on with integrative oncology or naturopathic oncology, the oncologists, it's sort of like it's perpetually 1970 for them, which is, yeah, that leads to those sort of comments that are nonsense.
So, what kind of do you work with all cancers, and are there particular types that respond really well to diet, or is it so individualized that even with a given type of cancer, it really depends on the person?
Yeah, I think essentially that's the sum and substance. Is it hits people, and really what I would say, having done this for a long time, is that integrative cancer therapies hit different people completely. They can have the same cancer, but their response is completely different. And that's kind of the same with diet. Now, what we see is there tends to be a core around diet that is helpful no matter what people have. And then you can be stricter or a little bit more lenient based on your personal response type of cancer. But what we always tell people up front is, and you see this, you could say the same thing for chemotherapy, really, but with any dietary or other health intervention that's not the big three in oncology, it's not so much, all people with breast cancer respond to XYZ. It's people with breast cancer tend to respond to these things, but you might be unique, and we might need to do more of one of them, or take one out or something. So there's a lot, because most diet and other natural therapies work with your body. And if your body is really weak, it may not be able to do the same thing that somebody with a stronger vitality can do. So we have to work around that and get the body's vitality up. But it tends to be, like I said prior, we start with the core of clean eating. So not a lot of we don't want outside chemicals. We don't want a lot of, say, preservatives, etc., other toxic material. um, we try to get really high, as I said, high density nutrient foods, and low glycemic type of foods. So we're not, feeding the metabolism with a bunch of, pro insulin and pro sugar sort of things. And then we customize it from there.
Uh, Any anecdotal, interesting things you've noticed? Again, have you worked with people that are stage 4 cancers, or is it always better to get them early? What kinds of adages or anecdotes have you seen that are really helpful to you in your understanding?
Yeah, we work from stage 0 to 1 to stage 4, because everybody needs help. And yes, I would say, as a general comment, if we get somebody stage 0, 1, or 2, there's a lot more you can do, and you have a lot more, long-term successful outcome, because you can affect those lower stage and grade cancers a lot faster and better. Now, that being said, many people are not diagnosed till they're stage 3 or 4. And so there's, unless they were involved in prevention or something, you have to treat where they come in. And of interest is, yes, the lower stage and grade cancers, much longer life if you look at all the stats and everything, even with conventional care. But back when we were doing outcomes research with stage 4 patients, in a research that I was involved in, people who did integrative oncology measures on top of any other thing they were doing tended to live longer than people statistically who had the exact same stage and grade of the same cancer who just did conventional oncology. So, length of life is a great measurement, especially at stage 4. And what we saw over time was almost every type of cancer that the patient had, where they would incorporate integrative oncology, they would live longer, which is super. It's not only very encouraging, it also is what people are going for. They want maximum quality of life, and then whatever extension of life they're able to get.
Well, what's the model? Do you, what if someone has an existing oncologist, a primary care physician? How do you work with them? Do you get pushback from their their current doctors that they're with, or do you have regular doctors on staff and then you try to integrate everything?
Yeah, it's a little of all of the above. What I would say to the bigger picture is if you go back 10 and especially 15 or 20 years ago, we would have patients who literally their oncologist would say, if you work with anyone else, I will not treat you. So the patients would come in and they would be afraid of losing their oncologist because they were working with someone else. Uh, that that type of attitude is changing, and that's a good thing. I will say you still run into that, but it's much less so than it used to be. So in the last 10 years, we've had a very slow but persistent increase in open-mindedness in the rest of the oncology community. And so what we try to do is inform and keep all the providers in the loop about what we're doing. And what usually happens in any part of medicine as far as collaboration goes, but especially in oncology, is in the beginning they can be kind of antagonistic or cold sometimes and sometimes not. But the more information you share and the more scientifically you say, well, this is why we're doing these things, the more bridges you build as opposed to walls. And what tends to happen, the best example of this is one of the I guess most antagonistic oncologists that we worked with during the research project that was a research partner actually. um, After a few years, he actually emailed me and said, I don't agree with what you guys do, but I will say that the patients that you and I share, that, so you're treating them, I'm treating them, seem to do better, have better quality of life. And it seems like their outcomes are better. So very, very slowly you get these sort of changes and you kind of build one oncologist relationship at a time. But in areas, you get to kind of maybe the center of the United States, where there's a little less exposure by oncologists to integrative oncology, et cetera. um, they can be pretty spicy about it, and basically say this is all crap, and you shouldn't work with these people because they don't know what they're doing. So it's one doctor at a time, really.
How do patients find you? How do they come to you? And are there any common stories when they come to you?
You know, whether so we're in our clinic is in Seattle, and Seattle is a decent size, metropolitan area. It also has quite a bit of presence of integrative oncology, naturopathic oncologists, and that sort of a kind of vibe to it. So people are a little more likely to seek you out, but largely it's kind of one of two propositions. One is they are near the end of their standard cancer treatment. So they've done, say, radiation and chemo, or they got surgery and they did 12 weeks of chemo, and then they're going to wait for 6 months and get another scan. That's kind of where a good portion of people come in and they say, all right, there's nothing that the oncologist is going to do for 6 months while we wait and see if the treatment worked, or 3 months, or whatever it is. What can you do for me to help me recover from the chemo and the radiation or the surgery? What can you do to, make my immune system come back online, et cetera? So that's sort of one population, is the after standard treatment group. The other are people commonly who may have stage 3 or 4 cancer, where it's more disseminated through the body, and they know that most likely standard therapies are not going to cure their cancer or make it go away. And so they are literally looking for things to either add on, or possibly they've been told that standard therapy isn't going to help their cancer. They're very motivated to find some other therapies to work. So that's sort of a different place for people. And we have to be more aggressive in that, usually in that instance, because they have a very aggressive cancer. And I would say there's a third area developing, which used to be very rare, but it's more common now. And that is what we call secondary prevention, where a patient is done with cancer, they're in remission or no evidence of disease, And basically their oncologist says, hey, you're in remission, come back if you start to have symptoms, or come back in a year for your follow-up scan. Patient will ask the oncologist, well, what do I do to make sure I stay in remission? And they'll say, well,
Mm.
live a good lifestyle, eat right. They don't tell them actually what to do. And we get those patients, and there's so many things you can do when you're in remission to promote uh, longer remission, staying in remission, et cetera. It's just secondary prevention it's not on the radar of the standard oncology community for the most part. So we do a lot of that now that people didn't used to come in for that. So that's a big positive, because it's actually preventing recurrence that we're working on there.
Yeah, what are some interesting things you've learned in keeping someone in remission? That's rarely talked about.
Yeah, it's it's an area it's exciting because the person is in remission, because most of the patients we deal with are having active cancer back. So then if you're looking at keeping someone in remission, you can literally then step back and say, well, what would have prevented the cancer potentially in the first place? And essentially what we look at is everything else about the patient's health that feeds into either a anti or pro-cancer metabolism and immune system, et cetera. So the areas we look at in people are, like we talked about, definitely their diet. We look into their movement and exercise, and are they?
Paul, so what, you said once someone's in remission, you want to keep them in remission, obviously, for sure. I haven't really heard this talked about at all. So what are some of the strategies you can do to keep people in remission?
Yeah, that's an excellent question. And as I had mentioned earlier, it's an area that's you don't hear about, and in the past, no patients ever would come in asking for secondary prevention, when they're in remission. And now people do more and more, because they realize they can modify things that would help their health in a way that would keep them in remission. So it's exciting to me because, we love dealing with our patients with active cancer, obviously, but that's a different problem. The cancer is still churning on. When you get somebody who comes in and says, I've been told I'm in remission, which is like, everyone celebrates that, which is great. But my oncology team doesn't know what to tell me to stay in remission, which is very normal. Do you guys have a plan or a protocol, or what you do for keeping people in remission? And we actually do, and we talk about it in the book quite a bit too, in prevention. So just so people know, primary prevention would mean you've not had cancer yet, but maybe it's in your family or something, so you don't want to get it. Secondary prevention is you had cancer, you're in remission now, or no evidence of disease, and you want to stay there. And that's very, legitimate. So the big picture things, and we really dive into these a lot in the book too, but if someone comes in and says, I'm in remission, help me stay there, we look at anything that either needs to be repaired after their standard cancer therapy, or anything that would negatively affect their metabolism or their immune system function. So if they come in and they're just beat down from having surgery and chemo or radiation or something, we put a lot of effort into getting their healthy cells healthy again. And we do a lot of that nutritionally and with lifestyle things, getting them to sleep better and, all that type of thing. Once the body has some vitality, though, that's when you have to be very aggressive if you're trying to prevent cancer from coming back. And so the areas, kind of the big picture areas we look at are what would affect their metabolic baseline. So the metabolic baseline is either pro-cancer coming back or anti-cancer coming back. And the things that we look at to get into that are actually the same things we do in treatment. We just do them a little differently and more aggressively. What are you eating? Is it something that is very, what we'd call sort of neutral to the metabolism? It's not stimulating a lot of insulin output. There's not a lot of high sugar content and bad chemicals and stuff like that. So what you're eating, how you're eating, meaning are you taking breaks from eating? So daily intermittent fasting, you stop eating at dinner and, don't eat for about 13 hours is associated actually with longer life and remissions. Um, and then clean eating. So make sure you're not putting, toxins back in your body because they're very triggering. And then there's how your body's working. So maybe you got really beat down, you're really fatigued, and you either lost a lot of weight during the process or you put on some, fat weight versus muscle weight. More muscle mass, because it's related to the anti-cancer metabolism inside the body. More muscle mass is what we work on because that's associated with longer remissions and longer life. So there's all those things, and then you add on to that, are they sleeping or not? Because actually, sleep wake cycle hormones are associated either with prevention of cancer or promotion of cancer. So not sleeping well is something we need to get people out of. So those things are one big area. And then there's what I call the the things nobody ever thinks to look for in a survivor of cancer. These are basically chemical things in the body that affect the immune function, either in a way where you resist cancer or a way where you promote cancer. And a lot of people nowadays, I mean, the term is very old, but nowadays people are more talking about epigenetics. And what epigenetics basically means is your genes are there with the code, but the epigenome, epigenetics, are the things in your life and that affect your life that actually either trigger good and bad genes or um, don't. And so this is why you see families where they have, say, some of the breast cancer genes and only part of the women get breast cancer, the other part don't. That's the epigenetic difference. So what we try and do then with the body chemistry and hormonal system is make sure it's as clean and epigenetically triggering of the good genes as possible. So the areas we look at there are toxin exposure. A lot of people have toxins they don't know about, but they become a huge thing if you just survive cancer. So we'll screen people for chemical, metal toxins, things like that. The hormone system is a huge manipulator of epigenetics in your immune system, et cetera. So we'll make sure their hormones are working correctly. They don't have too much or too little of them. Um, and then the other area we look heavily at in a more investigative way are going to be chronic infections, because those will drag down your immune system. And if you've survived cancer, often you don't get symptoms from these things, so you don't realize that they're doing it. So we actually screen people not just for their hormones and toxicity, but also for some of the more common chronic infections. And with
Well,
these,
quick question
yeah,
here. Quick question here.
yeah.
So do you see in general that people's bodies, even though they may be in remission, they're in a compromised state because of the chemo, because of the radiation and the surgeries, and therefore they're more sensitive, let's say, to disturbances or imbalances or non good habits?
Oh, certainly, yeah. And that's kind of the whole, that's the sum and substance of the secondary prevention things we focus on is everybody should be looking at these things. But if you survive cancer treatment is so hard on the body that it makes you much more open and sensitive to these sorts of disturbances. And then if these things are left to their own devices, the cancer that was in remission, may have very fertile ground to come out of remission. So yeah, it's a whole different body after, say, chemo or radiation or even surgery. So yeah, big deal there.
What's well, I really haven't heard of any new drugs or new interventions or anything that is to be given instead of chemo, instead of radiation. It seems like they have I guess pun intended or triple entendre, but these have a death grip on cancer treatment, chemo, radiation, surgery. I mean, so you have to work around them or work with them and help people, but any possibility there that these things just will not be used in the first place and these other therapies could be used?
Yeah, I think there's two answers to be, you know, give full disclosure here. If you ask a traditional oncology professional that question, um, where where traditional oncology's mind is, and it's not a bad place to be, it's just it's kind of narrow, is, well, we're developing all these new what they call targeted drugs, and those are the future of oncology therapy. And in the world of drug oriented treatments, that is the future of drug oriented treatments. Now these targeted therapies are not bad. They're a step up side effect wise from the older chemos, et cetera. But they're also not, these things are not going to cure anyone's cancer. Okay, that that's what it sounds like, but that's not going to happen. So to be fair to the standard oncology world, they're developing new stuff to try and replace or whatever, standard chemo. But really, they're not thinking of any other thing that might be useful. For us in the world of integrative oncology, naturopathic oncologists, and all, that whole community, we don't so much look at it as, you know, we're trying to replace chemo or radiation or whatever, as there are so many things that need to be done to help the body either fight the cancer, minimize the cancer, or whatever, that if someone comes to us and they have let's say they have a cancer where there's like a 80% 5-year success rate with a type of chemo, we're likely to say, hey, let's support, that's got good odds, let's support that chemo. We get a lot of patients come in and their oncologist literally tells them the chemo is so unsuccessful for your type of cancer. If it was me, I wouldn't even do it, which is, that's a change too, where oncologists are just saying that. And in some of the cases where we've had those patients where the oncologist said there is no treatment for you, or you're too old for chemo or whatever, we've had some of our best results with those type of patients, because you can actually access and work with the body and the immune system to extend their life through, again, getting the metabolism calmed down so it's not pro-cancer, and then getting the immune system anti-cancer essentially.
So if you had to have a Pareto of things that would help people, what would that be? Would that be diet first, exercise first? Would it be removal of the, environmental insults or toxins, and what the sleep? How do you look at it?
Yeah, I think, one of the things that happens with with the world of integrative oncology is you can get overwhelmed as a patient because ultimately you need to work on all those things, but sometimes you don't have the bandwidth for it. So one of the ways that we work with people, and this is something that I knew theoretically, but then looking back over a couple of decades worth of patient experience, it became very clear that without some basic pillars in the treatment of a patient, if they don't work on the big three first, then all the other fancy treatments, whether it's mushroom extracts or vitamin IVs or whatever, don't work as well, and they don't stick. And so what I always tell people is the big three pillars are all things you have control over that we can help you with. One is the diet and metabolic things. So what you're putting in your body for food and fuel, et cetera. Big area. The next is what we call muscle, which is muscle versus fat metabolism, and that's getting moving and all of that. And literally, muscle metabolism is anti-cancer. It's like longer life, et cetera. And the last of the three, so it's diet, muscle, and then the last is your mind. And the mind really reaches into a lot of areas. Of course, there's your own, it's really can be devastating, of course, to have a cancer diagnosis. Some people get so depressed that creates all sorts of other problems. Depression is not associated with longer life, and it's reasonable to be depressed, but you have to work on that, with the person and with maybe some professionals. But the other thing that the mind gets into is also your relationship, mentally, emotionally, to your cancer. That's a big epigenetic uh, factor, how you're thinking, but also your relationship with those around you. If you have a lot of really super negative people around you, you do not have as good of outcomes as people that surround themselves with supportive folks that are helping them. Um, and then because the mind is so intimately related with like sleep wake and the circadian rhythm, we usually talk to people about these factors of the mind. So there's the internal dialogue with yourself. If you have a mental emotional problem like depression, anxiety, that's got to be dealt with. Then there's the external mental stuff. What are your inputs? Like, you getting a bunch of negative crap every day, or you're really working on uh, uh, a realistic positive outlook. And then the recharging of the mind, which is sleeping appropriately, etc. So those are the big three. And I always tell people, like, it's true, over time, when I look at people who did really well with integrative cancer management or staying in remission or whatever, all of them were doing something with those three things every day. People who ignored their diet, you know, ignored the muscle versus fat thing, ignored their mental state, they could do a lot of effort into other therapies, integrative therapies, natural therapies. And if they weren't doing those big three, it's like it falls through a weak foundation. So those are the big three, really.
Well, getting a diagnosis melts your face off. I know personally. So,
Sir,
mastering the mental game is very difficult. That's probably, I would say, the number one thing. And then you're able to do all these things. If you feel like depressed and you're going to give up on everything, then you won't want to work out. You won't want to eat well because you feel like, what's the point? So I guess I would say that the mental is number one.
yeah, certainly. I mean, that's the biggest hurdle to get over, really. And it's not that you ever leave it, as you know. It's that you're dealing with it in a different way than when it first hits you. And you also, and I know I have seen people who they internalize. You get the diagnosis, it's the worst news you can get, pretty much, and they get stuck somewhere. They get angry or they get in denial or whatever. And you know we all know that if you stay there, that's not a healthy place to stay. But it's also, like you said, super intense and difficult to get your brain out of that so that you're motivated to do stuff. Yeah.
Do you find that people blame themselves, like they did something wrong and that's why they have cancer? Anything there? Like, do you have a psychologist on staff that kind of talks people through issues? Or?
Yeah, it's it is universal that people have any number of responses to their diagnosis, and one response is just what you brought up, which is, oh well, this is my fault, because of whatever. You could you fill in the blank, right? Um, and we work with psychologists, some psychiatrists, and some other mental health people who specifically focus their practices in patients who have cancer. And that's something that's becoming, much more recognized, but a lot of cancer patients are not told to, work with somebody. So yes, we definitely, on our intake, we delve into this with patients, and if they're not connected with somebody who's a professional in that area, um, we certainly encourage them to do that, and most are very willing to do it because they know, that they need help. They can't kind of gut through it on their own. So yeah, we work with mental health folks specifically focused on the cancer patient.
I don't know if you can help everybody or just people local to you, but what does someone do if they're not able to work with you for some reason and they want help, they need help? How can they even find someone that would help them? What should they look for?
It's an excellent question. And in North America, depending on your location, you may not know it, but like, let's say if you were in Seattle or Portland or certain places on the East Coast or whatever, there might be a lot of integrative and naturopathic oncology practitioners around, and then you might get to a place, like the Midwest or something, and there might be just a few. So there's a couple of ways to look. The first thing that I would recommend is there are board certified naturopathic oncologists in the United States and Canada, and they can be found through our professional organization, which is called the ONC ANP, so ONCANP. which is the Oncology Association of Naturopathic Physicians, and they have a referral service on their website, which is oncanp.org. But if you just do a search for ONCANP, you'll find the ONCANP. So that's one very, very good way and avenue. The other is, let's say you're in a place and you find nobody, through that search. The other would be to search integrative oncology. So 2 words, integrative oncology, because there are a lot of people, say, not associated with ONCANP, who do integrative oncology, and this is what a lot of the doctor-to-doctor training I do is for practitioners who are maybe MD or DO or nurse practitioners or PAs who have done extra training to become proficient in integrative oncology. So if the ONCANP search doesn't have anyone in your area, you can go and do a search for integrative oncology practitioner. And what I recommend with people there is just to look at the profiles of the different healthcare providers who do integrative oncology, and then unless there's only one in your area, I always recommend getting a quick call or look at their website deeply about their background, et cetera, and just see if you gel and resonate, because that's the biggest thing. But those are the 2 ways I'd search: ONCANP, find a physician, or integrative oncology practitioner.
And if a company or individual wants to reach out specifically to your practice, how do they get in touch?
The easiest way, the practice is called Advanced Medical Therapies, and the URL is advancedmedicaltherapies.com. You also can go to cancerandchronicdisease.com, and that'll get you to our website. If you're looking, say, on Facebook, it's just Advanced Medical Therapies in Seattle, and you'll find us there. And either through Facebook or through the website, all the contact info is there.
That's great. Well, Paul, thank you so much for coming. I really appreciate it.
Thank you so much for having me. It was wonderful. Thank you.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.